This is kind of just our presentation overview. Again, I'll be speaking a little bit about the genetics of myotonic dystrophies. I'm going to briefly touch on myotonic dystrophy type 1 and type 2. Julie Cohen's going to be speaking about preconception and prenatal genetic testing, different options that are available to you. And then Dr. Blakemore is going to be speaking about pregnancy in individuals with myotonic dystrophy. Okay, so I know that this is a rather busy slide. I think the most important thing to realize here is you all know, I think, the phenotype, the clinical manifestations of myotonic dystrophies 1 and 2 much better than I do. You could probably lecture circles around me. But really what I wanted to highlight here is just that we have myotonic dystrophy type 1 that's really broken down into 3 main categories. So in the first category, we have mild myotonic dystrophy. A lot of times these patients will go undiagnosed, and that's despite medical training with our neurologists. We have vigorous training that our neurologists will go through, our neurogeneticists, our medical geneticists, but a lot of times the symptoms are so subtle that they can go undiagnosed. And then we have our more classic form of myotonic dystrophy with a more juvenile onset in anywhere from 10 to 30. And this is where we see more of the facial weakness, the long face, difficulty smiling, oftentimes cataracts, and also some endocrinopathies like hypothyroidism and diabetes. And then we have a third category called congenital myotonic dystrophy. And so this is something that perhaps Dr. Blakemore might see prenatally, or back when Julie and I were both prenatal genetic counselors, we may have seen this in practice in pregnancies where there was not a lot of fetal movement or where there might have been clubfoot or contractures. We usually suspect myotonia. Okay, so I wouldn't be a good genetic counselor if I didn't have this slide up here. So this is going to kind of just goes over genetics in a quick little bit. So you see here over to the left a cell, and in each one of in our cells in our bodies we have genetic information, or DNA, and the DNA is carried along the chromosomes, and we have 23 pairs of chromosomes, 22 are numbered, and then we have the X and the Y, our gender chromosomes. So basically they house all of our DNA and our genes, and basically our genetic code that makes us who we are. It tells us how tall we're going to be, whether we're going to have, what color eyes, what color hair. But more importantly, we know that there are several hundred genes that are responsible for proper nerve and muscle development. And if there are changes in those particular genes, we see conditions like myotonic dystrophy. Okay, so here what I was just trying to do is talk a little bit about specifically myotonic dystrophy type 1. It's probably one of the most common adult muscle conditions that you would see, like in an MDA clinic. This something that we see very often. You can see here that I broke things down in terms of 4 categories, and I will talk a little bit more about what the CTG repeat is. If any of you guys are here in the room and you've had genetic testing, your doctors or your genetic counselors will have talked to you a little bit about triplet repeat or the CTG repeat. That's just the portion within the gene that's repeated over and over again. Okay, it's completely normal for it to be repeated up to about 34 times. Once it hits 34, it becomes unstable. Okay, so we have pre-mutation carriers. Those are individuals who don't necessarily have symptoms, but they have the expanded repeat. Then we have individuals with, we said before, the mild myotonic dystrophy, where we have very subtle symptoms and manifestations that's anywhere from 50 to 150 repeats. Classical is anywhere from 100 to 1,000, and then congenital onset is anything over 2,000. Okay? The important thing about myotonic dystrophy and other triplet repeats disorders is that we do see something called anticipation. And basically what that means is that when we see a family who has myotonic dystrophy, what will happen is oftentimes when mom passes on the repeat mutation to children, unknowingly, during the process in which the egg cells are made, the repeat kind of goes haywire and it multiplies. And so if I'm a mild carrier, for instance, if I'm a mildly affected individual, my CTG repeat could repeat from, let's say, 80 to 800 in my child without me realizing it, without me having any control over it. This is just something that we oftentimes see in repeat disorders. Most often it happens when mom passes on the repeat expansion, but it can also happen from father to child. I was just going to briefly mention myotonic dystrophy type 2. It's a little less common than myotonic dystrophy type 1. We see similar characteristics, but this is caused by a repeat of 4 base pairs. So, and we don't tend to see the anticipation that future generations have earlier onset. Okay, so here I just wanted to show you an example of a triplet repeat disorder. This is kind of a non-specific one, but basically what happens is we have internal spell checkers in our genes, and they can recognize if a word has been repeated, let's say 30 times. The cat ate the mouse. If the cat is repeated over and over again, our spell checker can realize, okay, this is a spelling error, let's cut out the cat. But once it hits a certain amount of repeats, our spell checker just doesn't work. And that's really kind of when the protein that's produced by that gene goes haywire and doesn't work the way it's supposed to. And this is what leads to myotonic dystrophy. Okay, here I just have, if you were coming to see myself or Julie, one of the first things we do as genetic counselors is we sit down with you and we go over your family history. So this is just a very plain example of a dominant condition. So when your genetic counselors or your doctors talk to you about myotonic dystrophy being dominant, this is something that we might see in your family history or family tree. So some characteristics of dominant conditions or autosomal dominant conditions is that we have affected individuals in each generation of the family. We have both males and females affected equally, and both males and females can pass on the mutated gene to their children. Okay, this is just another picture illustrating that if I have myotonic dystrophy, my chances of passing on the expanded myotonic dystrophy expansion is 50% or 1 in 2. That's not by choice, it's just my egg cells are already kind of pre-programmed to carry some egg cells that don't have the mutation and some that do. Okay. Something that's very important to me as a genetic counselor is having a molecular genetic diagnosis. So in some families we've seen individuals that have a clinical diagnosis. What's very important for prenatal purposes, and Julie's going to be talking about this a little more, is the importance of prior genetic testing. So if you are a male or a female and you have myotonic dystrophy and you are interested in meeting with Julie or another genetic counselor to talk about your prenatal and preconception screening options, it's important that you already know your repeat. Okay, so not that you know your mom's repeat, not that you know your sister's repeat or brother's repeat. It's important that you have been tested so that you are genetically confirmed and your exact repeat number is known. So what I put up here is a lot of times it's not quite known whether genetic testing is always covered by insurances. I work at the NIH, and I don't really have to deal with this because we have grants and federal funding that cover this. But it's very important for those of you who are seeing physicians on the outside that you might know ahead of time whether your insurance policy covers genetic testing. And if you ask them, hey guys, do you cover genetic testing? A lot of times they won't know the answer. But if you provide them with the CPT codes that I listed here, and something called the ICD-9 code, that's our diagnosis codes, they should be able to tell you right away if this is a covered cost. It's a relatively quick test. It usually takes about 2 to 4 weeks. Some of the genes I work with take 6 to 8 months for us to sequence them, and the testing cost is relatively inexpensive compared to other genetic testing. So I went ahead and called a few labs and just had them give me a range of how much it would cost, whether a person is self-paying, whether you're insured by an insurance policy, or whether it's institutional billing. If you work with a genetic counselor, usually we do a lot of homework on genetic testing and on cost of genetic testing. So we'll be able to help direct you in terms of which labs to select that are reputable, that have a good turnaround time, and that aren't too expensive. There is a wide range. Okay, and these are just some pictures that I pulled from a genetics textbook. Even though this is something that was first described, I believe, in the early or late 1800s, early 1900s in Germany, we still see families coming into clinic where, unfortunately, we have a severely affected child or young adult, and we have unaffected parents. So myotonic dystrophy, because of the fact that it's a triplet repeat disorder and it can expand when we make our egg and sperm cells, it can be very unpredictable. So a lot of times what happens is that when Julie sees patients in her peds clinic, or if I recently saw a 20-year-old who had very severe ptosis, so his eyes were very droopy. He had very severe swallowing difficulties and a lot of facial weakness and hand myotonia. And then he had parents who were in their 50s. Mom had cataracts in her 50s. It kind of a little red light went up in my mind. And then Dad had a cardiac defect, so he had a conduction. An arrhythmia. So again, it wasn't really clear where the mutation came from mom or dad. So that's why genetic testing is very important, not only in the individual, but also in other family members, so that you can let other family members know. So for us, it was very important to know whether mom or dad was the carrier so that they could let their family members know. That's not always something that's easy to do. It's hard to contact family members and share with them that you have an inherited disorder, but it's something that's very, very important, as this is something that can otherwise go undiagnosed in a family. So with that, I am going to pass the torch over to Julie.
Wonderful. Thank you, Elise. Thanks, everyone. So now what I'm going to talk about over the next few minutes is going over with you what are your options if you are an individual with myotonic dystrophy, as everyone in the audience is. What are your options for building a family? And I decided to call this section family building options rather than just reproductive options, because there's more than one way to have a family. And the 4 main options I'm going to go over with you today are something called IVF with PGD, prenatal testing, and then alternatives including using donor and adopting. So the first and most high-tech option is IVF with PGD. So IVF, we're going to use a lot of acronyms. I'll try to break it down, give you both simple explanations and a little more detailed. IVF is in vitro fertilization, where eggs and sperm are combined in a laboratory to create embryos, which then become the babies. And then PGD stands for pre-implantation genetic diagnosis. And this is genetic testing of embryos created by IVF, and then only embryos that do not have the genetic condition, that don't have myotonic dystrophy, would be transferred to the woman to start the pregnancy. So that's in a nutshell what IVF and PGD is, just to give you a little more detail in case this is something that you're thinking about for yourself. So in IVF, a woman takes medications, both pills and injections, to stimulate her body to produce many eggs, and this is monitored by frequent ultrasounds and blood tests. And then the woman undergoes a very minor surgery, an outpatient procedure where the eggs are retrieved and the male partner provides a sperm sample. And the eggs are fertilized in the lab by another fancy acronym procedure called ICSI, and I'll show you a picture of that. And the early embryos are allowed to grow in the lab for a few days, and then about 3 to 6 days after fertilization, a single cell or a few cells are removed from each embryo, and genetic testing is done on those cells to determine which embryos have the genetic condition and which don't. And then one or more of the unaffected embryos are transferred back to the woman to start the pregnancy. So this is just a picture version of what I just explained to you about how a single sperm is taken and injected into the egg. That's the ICSI part. And then the embryos grow, and a few cells or one cell is taken from each early embryo, and genetic testing is done on that embryo. And this is a picture of what it actually looks like under the microscope. It amazes me that it's possible to do this, that you can take off one or a few cells and not damage the rest of the embryo, but it really doesn't hurt that embryo. So the advantages of IVF and PGD is that it increases the likelihood of the birth of an unaffected child without the need for termination of an ongoing pregnancy, without the need for abortion, which is going to go along with the next options I'm going to tell you about. It is a very accurate procedure as well. The downside is that you don't get to get pregnant the old-fashioned or the fun way, as I like to say. You can still do that on your own time, but that's not how you would actually get pregnant. It is a lot to go through IVF. It's not necessarily a walk in the park. IVF isn't always successful, and you might need multiple cycles. And then a big challenge can be insurance and cost, because it is a very costly procedure. And I get asked this question a lot by my patients, well, how much does it actually cost, Julie, if I want to do this? The costs vary widely based on your circumstances and where you live in the country, but a super rough ballpark is that it's probably about $20,000 to $25,000 per cycle for IVF with PGD. Sometimes that is covered by insurance in whole or in part, and sometimes it's not. But don't assume that it's not covered. That's something that a lot of my patients say to me, well, Julie, there's no way I could afford that. My insurance definitely wouldn't cover it. Don't even tell me about it. I don't want to know about it. You would be surprised. And also, even if your insurance doesn't cover it, there are many resources available through the IVF clinics. They can offer discounts and refund programs. There's actually a whole industry of financing and loans for people who need financial assistance with fertility and with PGD. And then people even do crowdfunding. So there's a lot of resources out there. I put up here the website for Resolve, which is the National Infertility Association, and they have a whole listing of resources, financial resources and tips. So the next option, so that was IVF and PGD. Option is prenatal testing, where you would get pregnant, quote unquote, naturally, or the fun way, and then you do genetic testing during the pregnancy to determine if the fetus has DM or not, and that would give you the option to end the pregnancy if the baby was affected. There's 2 procedures. I'll tell you about each one. They're both highly accurate, and they do have a small risk of miscarriage. So the first procedure, called CVS, or chorionic villus sampling, not the pharmacy. CVS is performed at about 3 months into pregnancy. And then the second procedure, the amniocentesis, is performed a little later, about 4 to 5 months into pregnancy. And you would do one or the other, not both. So in CVS, it's a needle is inserted either through the abdomen or a catheter through the cervix, depending on the position of the placenta. This is all done under ultrasound guidance, and a small amount of the chorionic villi, which is the placental tissue, is taken, because the cells that became the baby are the same cells that became the placenta. So you can test those placenta cells and you get the genetic information of the baby, essentially. It's a minor procedure. It's pretty quick. The time that the needle is actually in you is maybe a minute. You don't need any kind of anesthesia. It's all done under ultrasound guidance. There is a small risk of miscarriage. It's probably about 0.5% or maybe a little less, depending on the expertise of the center where you're going. The other option is an amniocentesis. That's done a little bit later. Like I said, it's the same idea, which is let's get cells from the baby or cells that are the same as the baby and do genetic testing on those cells. This is done by a needle through the abdomen to take some of the fluid because that contains skin cells. Again, quick procedure, no anesthesia needed. And it's done under ultrasound. The risk of miscarriage is maybe about 1 in 300 or maybe a little less. And in both of these, the genetic results take another maybe 1 to 3 weeks afterwards. So the advantage of prenatal testing is that it's highly accurate. It is more likely to be covered by insurance than something like IVF and PGD. The disadvantage that you, at least today in 2016, you can't fix the abnormal gene. So if you find out that the pregnancy is affected, the option at that point would be to have an abortion. And the other disadvantage that there is a small risk of miscarriage that comes with the procedure. So then I'll tell you about the two alternatives to prenatal testing in PGD. One is to using donor eggs or sperm. And you might say, Julie, why would I want to use donor eggs or sperm? So you could use eggs or sperm from a donor who does not have myotonic dystrophy. So that's a way of ensuring that the baby wouldn't have myotonic dystrophy. Donor eggs and sperm are available from banks, from storage banks. Donor sperm can be inseminated directly into the woman's womb or used in IVF. And for donor eggs, you would need to do IVF. The advantage of donor egg and sperm is that you're guaranteed to not have a child with myotonic dystrophy and no need for genetic testing of the embryo or fetus, and the child is genetically related to one parent and the woman can carry the pregnancy. The disadvantage is that the child is not genetically related to one parent and this might not be covered by insurance. So lastly is adoption. There's many different types of adoption, domestic and international, closed or open. You could foster a child to adoption. So there's many different ways to do this. There's financial resources and tax credits. This Resolve organization also has a great section all about adoption and the ins and outs of it. And another wonderful website is childwelfare.gov that walks you through the whole process. So I learned a lot in researching for this presentation about what it takes to adopt a baby and all the different options there are out there. So the advantages of an adoption is that you're guaranteed to have a child without myotonic dystrophy and there's no need for any genetic testing, and it provides a home and a family to a child who needs one. The disadvantage, though, is that the child isn't genetically related to either parent and the woman doesn't carry the pregnancy. So those are the 4 types of options I just went through with you rather quickly. So how do you decide among these? So once, and I put this picture up here, this cartoon, because it cut off at the bottom, but what the caption says at the bottom is that all decisions involve risk. And you might feel like a little fish in the middle of all these big scary fishes trying to decide what is the best option for me and my partner and my family. So first you would decide whether to take action to prevent passing on a genetic condition in the first place. And in doing this, people think about what is the disease like, how early does it start, what is the quality of life like for myself and other individuals I know with this condition, and what's the availability of treatment currently as well as prospects for the future. Now, many of these aspects are subjective or uncertain, so there's not one decision that's right for each individual, and it's not just based on a textbook, oh, this is the symptoms of the condition and this is the probability of that happening. This is all subjective and it's based on your own, lived experience with the condition. So you come to a genetic counselor, to me or to Alice, and we talk with you about these aspects and help you come to a decision that's best for you, but really there's no right or wrong answer here. So when you're choosing among the options, ask yourself some questions. How important is it that the child be genetically related to you? How important is it that you or your partner carry your pregnancy? Would you be willing to terminate an affected pregnancy, and what will your finances allow? So these are just a few of the questions to ask yourselves as you are trying to make a decision. Some general advice I have for you is to try on each option. So to spend time imagining how it would feel like. So take a day to think, what would it be like if me and my partner went through IVF and PGD? Spend another day. What would it be like if we tried to adopt a child? What would that be like for us? What would your life look like if you went that route? Remember that different family members don't always agree. So myotonic dystrophy is a family disease. There's probably many others in your family who've gone through this, and people make different decisions, even faced with the same circumstances. There's no right or wrong choice. And if you're really struggling with a decision, genetic counselors are here to provide you guidance, but even beyond that, you might want to seek some short-term family counseling to help you kind of come to a decision that's going to be best for you and your family. And here are some resources: the National Society of Genetic Counselors, Resolve, and some fact sheets as well. So with that, I'm going to pass it off to Dr. Blakemore, who's going to speak with us about the maternal fetal medicine perspective.
Well, good afternoon.
Bring your slides up.
Okay.
Top of
Oh, cool. Okay.
right. Just a quick second. We have
Okay, and by way of introduction, I am an obstetrician and a geneticist. I'm actually maternal fetal medicine, and our prenatal genetics is something that's sort of housed within maternal fetal medicine at Hopkins. And we were talking earlier, we've seen a number of women in our obstetrical practices with myotonic dystrophy. At the same time, I think we've seen even more who are taken care of, not necessarily at the Big John, but are coming in for genetic counseling from all over. We probably see more women who have DM1 who are coming in for prenatal genetics. At least that's been my experience over the last, I guess, 30 years. Still waiting for the slides. I'm going to start out talking just for 2 seconds about DM1 and DM2, just because DM2 can present just a little bit differently, and DM2 is going to be milder, but there's a lot of clinical overlap between the two forms of muscular dystrophy. Oh, it didn't come up. We'd have to have the lights down real low to see them. Put everybody to sleep after lunch. But I'm mainly going to be focusing on DM1 this afternoon, and it is a progressive muscular disorder, and that is important from a number of standpoints of this talk, because many women present in pregnancy, and many women go through an entire pregnancy who don't even know, and their doctors don't even know that they have DM1. And so we'll return to that again and again. DM1 can present very mildly, and even in a mildly affected individual, there may be things their obstetrician ought to know. And that's what I was trying to put together this afternoon, is some of the things that patients and their obstetricians maybe ought to want to know if the patient herself has DM1. So pregnancy can affect a person who already is showing signs of DM1, and I'll go through that a little bit. And DM1 can also affect the pregnancy and how the obstetrical outcomes of the pregnancy, things that their OB anesthesiologist is going to need to know, in addition to their obstetrician. So it goes back and forth that way with many, many disorders, but DM1 is one of the most interesting. DM1 will affect a patient during pregnancy in terms of obstetrical outcomes, even if the baby does not have congenital DM1. If the baby does have congenital DM1, you get a whole another series of things that you need to think about, particularly as the obstetrician. So, we're going to skip through the first few slides quickly, because Lisa's already gone through some of the background. I'm just going to go ahead and see how things look. We've already talked a little bit about this, and the repeats, and the anticipation, and the fact that most babies that are born with congenital DM1 are from an affected mother. There's a few reports from an affected father, but it's usually an affected mother. And there are 3 types that we've talked about: the mild, the classic, and the congenital. This is a picture of a baby actually with a congenital DM1, and the neonatal characteristics, I'm sorry the slides are so dark, but are floppy baby, facial diplegia, that means bilateral facial paralysis. You can have a tent-shaped mouth, a form of clubbing of the foot. Respiratory difficulties are the big thing, because there's going to be some diaphragmatic hypoplasia that may develop in utero during fetal life. And there's going to be, despite the fact that many of these children improve after the neonatal period, there's still today about a 20% neonatal death rate with the severe form of DM1 or congenital DM1. Sometimes you'll see a little bit of ventricular dilatation in the newborn and sometimes in the fetus, and the survivors have a significant learning disability. This shows a baby with, sorry about this, but with a heart block, and heart block is something you have to watch throughout life for those children as well as the adults who have DM1. The next slide shows a patient who has classic DM1. So classic DM1 usually shows up sometime during adult life, and it is because it is something that is progressive. You will find that the older the patients are, the more likely you might see some manifestation of it. But again and again, there's many, many women of reproductive age who have not manifested very much and may have actually been undiagnosed until sometimes the pregnancy, for one reason or another, brings out the fact that they have DM1. So we're going to talk for a minute now about this effect of pregnancy on a patient who is already manifesting signs of DM1. And what you might see is muscular weakness and myotonia, which can stay the same or actually may worsen. Usually, if it worsens, it comes on about 28 weeks. It comes on in the third trimester, and it may be an effect, a hormonal effect, but maybe of progesterone. But it's really unknown as to why this phenomenon occurs. It can present earlier. It certainly can present later in pregnancy as well, but as far as increasing in weakness. And then, curiously, you'll see over and over again that it often improves right away, right after that placenta's out, right after that baby's born, or during the first few weeks postpartum. So that lends more credibility to the fact that there may be some kind of a hormonal effect on the DM1 in pregnancy and its manifestations. It's very important that we know about the diagnosis, because there's a drug that's commonly used for a variety of scenarios in OB/GYN and obstetrics called magnesium sulfate. It's good old magnesium. It's used for preeclampsia, and whether or not you have DM1, you, as your first pregnancy, would have about an 8% of having preeclampsia, and that's also known as toxemia of pregnancy commonly, where you get high blood pressure and swelling, and magnesium sulfate's used to prevent seizures in patients that present with that. We use magnesium sulfate also for complications of preterm labor, and you really have to be careful with it in a patient who has classic DM1, the mom. Also, the anesthesiologist is going to have to be cautious if a patient has DM1. Any of the respiratory depressants can actually be aggravated by the DM1 diagnosis as compared to someone that does not have DM1. And general anesthesia is of particular risk because of the exaggerated response to paralytic agents. You may run into a very prolonged intubation period in a patient who had, say, a cesarean section that had to go under general anesthesia, or for any reason, operation under general anesthesia. There's a diminished cough reflex, so you can have an increased risk of aspiration pneumonia that the anesthesiologists and the doctors need to be aware of. And then there's the cardiac arrhythmias. And this is where I come back to DM2, which you can't see on this slide, but it turns out from a very recent paper that the tachyarrhythmias are actually more associated with DM2, although they can be seen in 10% or less usually of patients at some point in their life with DM1. So that's supraventricular tachycardia, meaning above the ventricles, above the atria, or ventricular tachycardia. But in DM1, you'll get more conduction defects that were mentioned earlier, and congenital heart block. And these patients are at risk of sudden cardiac death. So if a patient comes and she hasn't had one recently, we're going to recommend that the patient who she herself has DM1 is going to get a baseline EKG and a baseline Holter monitor to see what's going on there. And also have her being followed by a cardiologist. So whether or not the baby has congenital DM1, the DM1 can affect the mother's pregnancy. And sometimes, in fact, the patient's gone undiagnosed, and it's the obstetrical complications that actually clue people in that the mom has DM1. The complications from DM1 are related to decrease in myometrial contractility, so the smooth muscle doesn't contract well. And that leads to a number of things that can affect all 3 stages of labor. The first stage of labor is labor itself from 0 to 10 centimeters before the patient gets to fully dilated. And she may have failure to progress because that uterus is just not contracting regularly or as effectively. And she may also have failure to descend in the second stage. So the second stage is the pushing stage. And she may not push effectively if she's affected with DM1 due to weakness. And finally, after the baby's out, you want that uterus to contract. When the uterus contracts, that's how people stop bleeding. And if it doesn't contract well, you'll have an increased chance of bleeding through uterine atony. That means the uterus is staying sort of flabby. It's not coming down like a nice hard ball. And you can have a obstetrical hemorrhage as a consequence. Now, the affected fetus is going to compound this situation. So if you have a baby with congenital DM1, you yourself have DM1, you're going to have a compounded effect during the pregnancy. And again, it's unfortunate in a way, but good in a way too that they're very mild. But many of the women do not know they have DM1, and their physicians don't know either. It's always better to be prepared so that it's not the obstetrical complications that make the diagnosis for you. So the fact that the baby may have congenital DM1 is actually could be a blessing in disguise. There's a paper back in 1984 by, it looks like he has repeats in his initials on there, but by Dr. Cohen, you shake hands, of the mothers with floppy babies, because this is how, classically, you might make the diagnosis of DM1 in the mother. And we've already gone through the neonatal characteristics of congenital DM1. Now we're going to look at what's going to happen during fetal life, because in utero, the fetus with congenital DM1 presents in a very, very similar fashion to the newborn who's affected with congenital DM1. Most women during a pregnancy, if they have a baby who is affected with a severe form, are going to experience decreased fetal movement. And this and the other fetal manifestations are actually able to be visualized by ultrasound. Here's what happens is the fetal hypotonia and the myotonia leads to decreased fetal movement. Decreased fetal movement leads to the facial diplegia. The baby looks like it is just not moving its facial muscles in utero, and you may see the tent-shaped mouth. It does not move its feet in utero. You may end up with a baby, you could see the talipes in utero. And in addition, the babies don't move themselves around as well, and they often end up as a breech presentation. The same thing, the fetal hypotonia myotonia causes decreased fetal swallowing. This leads to something highly, highly significant, which is polyhydramnios. And here's a picture. This was the picture of a month from an article in 2002, and this shows the tent-shaped mouth. This is a baby who just lay with the mouth open, does not move its extremities either. It doesn't move its facial muscles. There's polyhydramnios, and usually that leads to excessive fetal movement. So when you see polyhydramnios and no fetal movement, that's going to be one of your first clues. This is a baby with the tail piece of the foot. And this is a baby that this is not as common, but may present with a little bit of dilatation of the ventricles, of the cerebral ventricles in the head. Now, so we're repeating the slide from earlier where we looked at the effects of congenital DM1. Now let's look at, in the brownish color, the effect of it on obstetrical outcomes. So when you have the baby not moving and you end up as a breech, you're going to have increased risk of cesarean section. When you have polyhydramnios, you're going to end up with several risks that are actually fairly common. One of them is called PPROM, which is premature rupture of the membranes, where the membranes rupture sometime before 37 weeks of pregnancy. Preterm labor because of PPROM. Preterm labor because the uterus thinks it's bigger and it wants to contract when there's polyhydramnios. So they go into labor earlier. Anytime you have an overdistended uterus from something like polyhydramnios, be it twins or other things, you're going to have an increased risk of preeclampsia. And lastly, we talked about the fact that when you have polyhydramnios, the uterus is just really overdistended and it doesn't want to contract after delivery. So you have the risk of uteroanatomy and postpartum hemorrhage. Shown in a different way, if we have a congenitally affected fetus, you have decreased muscle tone. Sorry, the slides have gone on to at least a format you can see, but they're a little off. Decreased fetal swallowing, it's supposed to say, which leads to the fluid not getting going on through and being absorbed by the fetus, so it builds up around the baby as polyhydramnios. Polyhydramnios in turn causes the four things that we talked about. Everything's kind of moved around here. We talked about the fact that you may end up as a breech, and the fact that there's decreased fetal movement ends you up with some of the fetal findings that you'll see on ultrasound. What this slide is supposed to show is that when you have a baby that's a breech, you end up with an increased risk of cesarean section. And honestly, when you have PPROM, preterm labor, preeclampsia, you will end up with an increased risk of cesarean section. Cesarean section itself is a risk for bleeding. And in a patient whose uterus may not want to contract down very well, it is not the operation of choice. Fortunately, this one came out a little better. Fortunately, when the mom herself's effects of DM1 are looked into, you do have the option, if she's gotten to the second stage of labor, gotten the baby down, of just doing a simple operative delivery that is a vaginal delivery. But sometimes you can't, and you're going to end up, for that reason, with a cesarean section. And again, it's not the delivery mode of choice for someone that has myotonic dystrophy, because there's an increased risk, mainly because of the increased risk of hemorrhage and postpartum hemorrhage. I thought, since this session is called family planning, I would just talk for a minute about contraception. Looked it up, there's nothing in the literature on contraception in DM1 specifically. But if you think about it, there's no contraindications for any form of contraception with DM1. Now, while progesterone, we just said, might aggravate the symptoms of a woman who has classic DM1, the doses are very different than what they are in pregnancy, and so she would be allowed to try to use oral contraceptives that contain progesterone, IUDs that contain progesterone, implants that are long-acting forms of reversible forms of contraception that use progesterone as well. The non-hormonal IUDs, interestingly, might cause increased bleeding, and that might not be your best bet in some patients whose uterus is not apt to contract well to begin with, but any of the forms of contraception can be tried, and their patient's response is going to be individual, just like it is in the general population. Sometimes one form of contraception is more acceptable to a patient than another. The individual's DM1 disease progression, I think, is a very important point to just rest on for a minute. You want to have a pregnancy while you're healthy. So the best situation would be to think about family planning more on the early side, and at least not delay childbearing, knowing that your DM1 could only become more manifest as you get older if you already know you have classic DM1. And the last thing I thought of was that a postpartum tubal ligation, if the patient's had got, say, an epidural for her labor pains, probably safer than waiting, if that's what she wants to do, as a tubal, and then waiting for that tubal ligation to be done as an interval procedure, which is generally done under general anesthesia. And we've already said that general anesthesia is the best option for the patient. So my conclusions in the summary are that many women with classic DM1 are asymptomatic, and they're not diagnosed before they conceive. And that's actually true today as well as it was not as often, but it's still true today. Maternal DM1 can lead to obstetrical complications even if the fetus is not affected. Congenital DM1 can further complicate her pregnancy, labor, delivery, and postpartum course. And the recent case series described that almost 50% of classic DM1 is not diagnosed, or is being diagnosed, through an offspring who is affected, either in the newborn nursery or during pregnancy. And in light of the potentially life-threatening and avoidable obstetrical complications that could ensue, prenatal recognition of congenital DM1 is very important, not only for the fetus and planning for where should that fetus deliver, et cetera, maybe not in a small community hospital, but also for the mother. And as devastating it is, the diagnosis, making that diagnosis of congenital DM1 in the fetus or the newborn can provide the key to appropriate planning and OB management decision-making that can be life-saving to the mother. Oops, so we lost the last slide. So my last slide was that same guy, who said, do you shake hands with the mothers of floppy babies? And it's, do you shake hands with the mothers of women, of fetuses who have, the ultrasound findings of congenital DM1. So that's it. And I think we're all ready, willing, and able to take questions. Any questions that anybody has? Thank you.
Thank you to the three of you. It was just sort of extraordinary amount of information, and just thank you, Karen, for your ability to proceed without slides. Usually it just sort of,
So pretty.
your brain just sort of stops, and it was our technical problems of one PowerPoint machine and another but we've got, before, the wall is going to start moving soon is what I'm guessing, because we're going to have a plenary session in here. Are there questions that you want to raise at the moment, or you can see? Oh, put them on index cards. The other issue is the slides are going to be posted on the MDF website, so you won't have Karen to sort of decode them for you, but they'll be available.
I have handouts that I brought with me of most of the slides. I mean, the ones that, kind of go serially on top of each other, just made the one ends. But if you'd like, if anybody would like one, I have about 20.
Perfect, okay. I mean, just again, let's thank our panelists. The amount of information was extraordinary.